So I'm a clinician and I'm a neurologist, as was mentioned, but I'm a cognitive and behavioral neurologist. So neurology, just like internal medicine, we're very subspecialized. And so if you have the opportunity, if you have changes in memory or thinking as you get older, or due to a head injury or a stroke, a cognitive neurologist is a person that can help, and that's my background. And I've been practicing in southern Louisiana for over 25 years, and I'm also an academic physician, so I do research and educate students, but also the public, and I'm really excited to be here. So how many of you all are people that have cognitive decline, or any people here that, and how many people are caring for somebody with cognitive decline, Alzheimer's, or another type of memory loss? And how many people are people that are worried about it or have a family member that they may be worried about? Okay. And how many people are, physicians or clinicians, public health people that are interested in, okay, thank you. And some of us have dual roles. And so in this talk, I'm going to try to very quickly talk about some of the risks for cognitive decline. And we know that age-related cognitive changes are not really one thing, but I'm going to emphasize Alzheimer's disease because it is the most common form of dementia worldwide. And also, we've made so much progress in the last 17 years. There was a gap of 17 years where we didn't have any new FDA-approved medications. And the early ones that we had treated symptoms. They didn't treat the underlying pathology, potentially to modify disease. And so I think what's so exciting about being here with nuclear medicine and molecular imaging experts is that there's this real partnership with physicians in my field and related fields in trying to earlier detect people at risk or people that are in the process of evolving this cognitive decline and intervene as we get more and more drugs approved from the FDA that really target the pathology of Alzheimer's. So it's an exciting time. I think in the next 5 to 10 years, it'll be amazing because the process develops over 10 or 20 years, so many of us now have some of this pathology and may or may not go on. But you want to prevent it, just like you prevent heart disease, right? Or you prevent stroke. You take your statin, try to, prevent, do insulin-resistant treatment, right? So at any rate, let me see if I can make sure. What do I do?
I would just use the arrows on the
Use the arrows. Oh, okay.
This is just going to fall. Just forward.
So I'm left-handed, so I can always use that as this. There, I got it. I was using the wrong arrow. So see, even with us, we have to be educated about what button to push. I should have done that while I was waiting. At any rate, so this is sort of a statement of the problem. So 50 million people worldwide have dementia. And as I just mentioned, Alzheimer's is the most common form. So 1 in 9 people over 65 years of age have Alzheimer's disease. It's about 7 million in our country. And it's the 5th leading cause of death in 2024. The age of onset, I don't know how many of y'all are from Louisiana that are in the audience? Maybe some people that are online. Well, at any rate, the age of onset is younger here in Louisiana. We're also 50th at risk, so our population has the greatest risk for developing Alzheimer's or another type of dementia. And we know that the annual cost of this is astronomical in terms of the direct cost for patient care and treatment. And then the indirect cost, I think what's really remarkable is that caregivers, and many of you in the audience may be caregivers or concerned that you may be a caregiver in the future with a family member, but on average it's 22 hours of unpaid care that people devote to their loved ones. And it's a very difficult disease, as we know, and it's difficult to watch. So this is from a study that we published. Actually, it was a chapter a number of years ago, but it just shows worldwide. You can see the pie, so 20% of individuals are vascular dementia, the second to most common after Alzheimer's, which is 40%. And then 15% are mixed dementia types. That's really common here in southern Louisiana, especially vascular dementia with Alzheimer's disease as a mixed type. 10% are frontotemporal dementias, and 15% are others. So that can include things like multiple sclerosis, infectious causes, traumatic brain injury, things like that. So there are multiple risk factors for dementia. And a risk doesn't mean that you're going to get it, but this is the most recent data that shows that there are now 12 that we consider risks for dementia of any type, including Alzheimer's. And that is physical inactivity, smoking, excessive alcohol use, air pollution, head injury. People without social contact, so social isolation, less education, obesity, hypertension, diabetes, depression, and hearing loss, hearing impairment. But if we assume a causal link between these risk factors and dementia, so of Alzheimer's type, for example, as many as 40% of all cases of Alzheimer's are attributable to these risk factors. And so what that means is some of them are modifiable. So if you move more, if you exercise more, if you smoke, if you stop smoking, if you drink less, if you lose weight and you treat your chronic medical conditions, it can improve and reduce the chance that you'll have clinically significant cognitive decline or Alzheimer's. So just for a minute, I'm going to talk about the pathology. And again, Dr. Dubroff made reference to this in relation to how we can actually in vivo, so in life we can image people and look at the burden of some of these abnormalities. And he focused on amyloid, but it's emerging that tau may be something that we will use in the clinical setting in the near future as other drugs are developed that maybe target tau as another one of the pathological contributors to cognitive decline in Alzheimer's. So normally these two proteins, which are in the cells, as he mentioned, the amyloid plaque is extracellular, so it's outside of the cell, and the tau is inside. But they're both involved in the structural support of healthy cells, but there's changes in the proteins that make them toxic. And with normal age, we all get these abnormal changes, but when there are more of them in an individual and they disrupt these brain networks that are involved in certain cognitive operations and they're localized in specific brain areas, for example, in the hippocampal formation important for memory function, that's where earliest on there is a huge burden of these two pathological changes in the nerve cells. The nerve cells die, the cell-to-cell signaling is disrupted, and then the brain shrinks in those areas. And it contributes to the cognitive deficits you see early, or the initial complaint when you go to a doctor. So memory complaint, difficulty naming, difficulty navigating in unfamiliar places is because of the localized changes and the disruption in the cell signaling and brain function, and ultimately shrinkage that then becomes more progressive and distributed throughout the brain. And these are some examples. So you can see on the left, A shows a healthy brain, and then a healthy cross-section of the brain that's not shrunken, and then a healthy nerve cell. And then below, how the brain shrinks, and then you can see in the cross-section the shrinkage, particularly in the inferior part. That's the temporal lobe where the hippocampus is, that area important for memory. So the cerebrospinal fluid-filled temporal horn there gets larger because the brain shrinks around because of the pathology in that adjacent structure that is important for memory. And then you can see the A beta, the abnormal plaques, the amyloid plaques, and the tau, the hyperphosphorylated tau. So those abnormal structural changes in the neuron disrupt it and disrupt function. And you can see on the right side of this slide an example of, on the left side of the brain, a healthy nerve cell, and on the right, when the brain is involved with and afflicted with these pathological changes, the brain shrinks and then the cells die and it continues to progress. And so this is just an example. I know my colleague talked a lot about some of the physics, behind and the development of these sort of exciting technologies and diagnostic studies that we use. But you can see normal, I think of it as, it's cool to be normal, so you have those cool colors, the green and the blues, and it's not good to be hot. Well, like we're hot right now in New Orleans. Maybe that's why we have more cognitive decline, but you see the red and the yellow. So that's, when you start to see the abnormal changes in terms of, focusing on amyloid PET imaging, which is what we're talking about in this session and trying to help you understand in relation to the latest treatments that we have that can stop or delay progression of the disease. And this is, again, I view this as sort of like a thermometer, if you will, so healthy to the left, sort of the green, and as you get more and more increased burden of plaques, and some people do more quantitative analysis and regional assessment of the amyloid burden on PET imaging for diagnostic study or research. So what I'm going to do now is I'm going to shift and talk about 3 cases. And I was hoping that you can maybe talk about the amyloid imaging that is relevant to each of the cases so you can see an example of disease progression, okay? So the first case is Mrs. Harris, who is a 71-year-old business owner who's been having trouble multitasking in the past 1 or 2 years. Her daughters are concerned about memory loss. She has had recent stressors. She is functionally independent. So the important thing there is that she's high functioning. She's 71, so she's over 65, so wouldn't be early onset. And she has stressors, but no other medical problem that's been identified. And that she's functionally independent, that's really important. So her medical and surgical history is really unremarkable. Family history, so her mother was diagnosed with Alzheimer's at a more advanced age, at 80, and her father died at 55, so we don't know if he would have had some sort of cognitive problem earlier. The social history, so she lives independently, social alcohol use, no drug use or cigarette smoking. So on cognitive testing, she recalled 2 out of 3 words at 5 minutes. She had mild difficulty with serial 7s, but no other cognitive deficits. And the elemental neurologic exam, so I don't know how many of y'all have been to a neurologist, but cranial nerve, sensory, motor, cerebellar gate station. So no abnormalities on elemental exam. And on the cognitive exam, she really didn't have any abnormalities. So on the memory testing, in this, looking at 3 of 3 words with a short and a long delay, you should get 2 or 3, no matter what your age is. And getting 0 or 1 would be abnormal or impaired. People with Alzheimer's typically have 0, and oftentimes they don't even remember that you gave them the words. The serial 7s is a test of attention, so she had some mild difficulty, but no other. She didn't have any naming problem, visual, spatial, or executive function deficit, so that's all important. So basically, this is a woman with a complaint. Her children have noticed a change, and so she's concerned and worried about cognitive decline, but on objective testing, it's normal, no abnormalities. So here's the FDG PET and the MRI.
All right, just want to make sure this is on. So we have with MRI, this is a coronal, so kind of down the front, and this is a side-to-side MRI. And they really don't show any type of tremendous abnormal atrophy. This is a FDG scan of the brain here on the left side, and remember, unlike the last image that Dr. Foundas showed you was an amyloid image, so we have to know what tracer we're looking at because it's a much different interpretation. And so here we don't have a gap. We have glucose metabolism throughout the brain without a regional gap that we might see in a dementia. And this is just, we're able to fuse the 2 images. There are PET-MR scanners where they can be acquired at the same time, but with software, because the brain doesn't really change shape as you go from one scanner to the other, we can fuse them, and here is just, it looks to me like a pretty normal MRI and a pretty normal glucose map of their brains.
Okay. And here's the amyloid PET.
Yeah, and then this patient also has an amyloid PET, and again, we have the same kind of MR, and then this is the black and white image of the amyloid scan, and this is just fused using the blue yellow. So a positive, we might see some yellow that ends up in the gray matter. These little, we call them sulci, these little grooves on top of the, not grooves, but these little tissue here, these are grooves, the sulci are the one that's next to it. And just from this, we don't see any abnormal amyloid accumulation. So I would also call, so the prior study I would call normal glucose metabolism, and this one I would call negative for abnormally increased amyloid deposition. We know that the signal just sticks to the white matter normal.
So this is the second case. So this is a patient that came in with a cognitive decline. So Mrs. Lewis is a 59-year-old executive who's been having trouble learning new people's names. She often forgets about meetings that she arranges herself. Her ability to speak well is declining. She is functionally independent. So again, the important thing is she's still functionally independent, but there have been some changes. Again, like the patient in case 1, no significant medical or surgical history. In this case, no contributory family history. Social history, she lives with her husband. Social alcohol use, no drug use or cigarette smoking. On cognitive testing, so this is a difference, she recalled 0 of 3 objects with a short and a long delay, so that would be clinically significant memory loss. She had some word-finding pauses in conversation, but on confrontation naming, she did okay. And no other deficits, so visual spatial function, executive function. Again, she's high functioning, she's educated, but there are objective changes, and she's still functioning independently, and her neurologic exam is non-focal, is unremarkable. So again, it's different than the prior patient. And here's her FDG PET.
Thanks. So what we see here is we see kind of these decreases. Again, this is a glucose map. We see focal decreases here, and this is the left parietal lobe. This is down here, the left temporal lobe. You can see the asymmetry now. You're saying, oh, you're getting your left and right confused, but the way we interpret images is actually as if we were looking from the foot of the patient's bed. That's classically how we're trained to look at images. So I actually know the difference between my right and my left. I should just mention that. And so we see it here in the left parietal lobe, left temporal lobe here. And so this would be someone who could have a neurodegenerative disorder, and because it's on the left side of their brain, that's where a lot of your ability to make speech and understand speech, those are in separate areas. I may think this patient might have some word finding or word understanding problems, but not entirely specific, but this could be an Alzheimer's type of situation. Definitely abnormal and definitely worrisome.
Well, and again, remember, she did have the word-finding pauses, but perhaps with more extensive testing, neuropsychological testing, there may be some more cognitive findings given her level of education and function. And here's the amyloid PET, and you can tell there's a difference, right, compared to the patient and the imaging.
Yeah, so instead of those like just wispy interdigitations that don't extend out to the periphery of the brain and the sulci, we see this kind of blurring of the white and the gray matter, especially in, I would say, the right temporal parietal region here, and definitely you can see there's more signal here in the frontal lobes. So this is a positive amyloid study for sure. So this is consistent with a diagnosis of Alzheimer's.
And this is case 3. So cognitive decline. This is Dr. Barnes, who's a 79-year-old professor with progressive cognitive decline. He has memory loss and word-finding difficulty. He stopped driving about a year ago because he was getting lost. No significant medical or surgical history, no significant known family history. Social history, he moved into assisted living about 2 years ago. He has social alcohol use in the past, no current use. He denies drug use or cigarette smoking. On cognitive testing, on delayed recall, 0 out of 3 words, so again, impaired. Impaired confrontation naming to low frequency words. So, you ask, what is this? So it's glasses, what is this? The lens, what is this? The frame, what is this? So he could get the watch, but he couldn't get the band, for example. He had some difficulty copying a complex figure. The elemental neurologic exam was non-focal. So this is a classic picture of somebody with profound memory loss, anomia, so naming problem, which is left parietal, and a visual spatial function deficits, right parietal. So the classic presentation clinically of somebody with probable Alzheimer's. But again, let's look at the imaging.
So again, this is a FDG, this is a glucose map, and these pictures here are kind of trends axially across the brain, and this is one that's actually right down the middle. I did that for a reason. So you see there's really decreased bilaterally, maybe a little bit worse on the right than the left of the glucose metabolism there, very, very stark. And then you see here, it almost looks like a giant divot out of here. This is a region called the posterior cingulate and the precuneus region, and that's very specific for Alzheimer's disease. So I'd be pretty comfortable about calling this Alzheimer's disease just based on the glucose map.
And then this is the amyloid PET.
Where again, we see a lot of amyloid throughout the brain, the blurring of the gray and white matter and the deposition of amyloid in the gray matter where it shouldn't be. So again, consistent with our diagnosis.
So these three cases are showing some of the, in a sense, the progression or the differences in degree, if you will. So in the first patient, remember she had some changes that had been noticed by her family, but no objective deficits on cognitive testing. And her imaging findings were really not abnormal. I'd still be concerned about her, but by definition, because there are no objective cognitive deficits, the diagnosis is subjective cognitive decline. Not all those individuals go on to advance to mild or minor neurocognitive impairment or major neurocognitive impairment, which is dementia. And the difference is dementia, it's a continuum. We have to make these discrete diagnostic differences, but it's a continuum, and it's the clinicians talking with families, because there's a mild change in your ability to function independently, but when you no longer can function independently, like case 3, who was now in assisted living, Dr. Barnes, then you meet the criteria for dementia or major neurocognitive impairment. And again, it's not one thing, but in this case, it looks most like Alzheimer's and with the amyloid imaging. And the second case in between, who has some objective deficits but is still relatively independent and functioning. Now, if you go through individual things, maybe this person is needing more reminders for appointments. Like, she even gave that history. But if you do one of these, functional index measures, if you will, maybe she has more difficulty preparing her taxes, things like that. So there are some changes in her ability to function. But again, minor neurocognitive disorder or impairment, and then when there are some changes in amyloid in this stage, would be when a physician like me would be interested in saying, do you want to consider infusion therapy, or do you want to consider disease-modifying therapies? And again, with all of these patients, I would certainly start them on Namenda and Aricept, which is sort of what we have for symptomatic treatment. But I'd also make sure that I'm not missing something. So in the first patient that was, experiencing more stress, and again, she had some attentional problems. Could there be a sleep disorder? Could she have, with the stress, is there some depression? I don't know, other things that are treatable. But those are sort of the cases and the diagnoses, if you will.
Can I just make one
Sure,
comment on the imaging?
Go ahead.
So the imaging we showed the most severe advanced dementia on the continuum, as Dr. Foundas mentioned, had the most amyloid. But actually what we found is that the amount of amyloid is not proportional to how functionally the functional amount of deficits a patient might have. If there could be a little bit of amyloid, but the glucose metabolism could be really abnormal, and there could be, but we've also found that tau is proportional to the deficit. So more tau and a much greater functional deficits. So amyloid, it's just positive or negative. If there's more amyloid than it should be, that's absolutely. So the two amyloid maps of the last two patients could theoretically be interchangeable. In terms of how we look at it in terms of where a patient might be on the spectrum.
Well, and then the other thing is there are people that have a positive amyloid imaging study and they don't have any cognitive deficits. They don't have any objective deficits on testing, no complaints. And so there's this subgroup of people that, again, it's not diagnostic. It's not pathognomonic, if you will, right?
And that's again why we want someone like Dr. Foundas ordering the tests, not using it as a screening test. We really want people, per our agreed use criteria for this amyloid test, to be someone who sees a lot of dementia patients, to say this particular PET test might be the right test for you. But if you don't qualify for it, she should be the one deciding, because she sees so many of these patients. She really has a good idea who it's going to be useful for.
And excuse me, and you know, why I started off early with the 12 risks for Alzheimer's, and it's just even for healthy brain aging, which we use now. We used to call my clinic a memory disorder clinic. Now we have a healthy brain aging, you know, center or institute, whatever you want to call it, that's more positive. But it's because I think we do have treatments, but also if we target some of these other things early on, so in midlife, if you have a jump in your cholesterol, you need to have it treated. If you have high blood pressure, if you have, you know, a sleep-related problem, if you have hearing loss, if you're overweight, or you even, you know, not overweight with insulin resistance, it's one of those things. Inflammation is really, and there's over 110 different drug studies with multiple different targets in the pipeline. But let me go on so I was just going to go over what the definitions are of these diagnostic groups, if you will. So subjective cognitive decline, that the person is functionally independent and no deficits on objective testing. So in Louisiana, 1 in 7 adults over 45 years have this, and so I would say a lot of those individuals are at risk. Not necessarily that they're going to get it, but they're at risk, not just for Alzheimer's. And that's 14.6% of our adult population. 11.2% of adults in the United States over 45 have subjective cognitive decline. It's certainly more prevalent in rural areas, in more impoverished areas, so I think that's important for us to think about. And some of the things when we were talking about going on Capitol Hill and lobbying, it's for certain things where we can try to educate more rural physicians to be able to do better diagnostic testing of people with cognitive problems in our country. So mild cognitive impairment, again, it's a continuum, right? And oftentimes these mirror the pathological changes in the brain over 10 or 20 years before the person presents clinically. But mild cognitive impairment, so they have deficits on cognitive testing, like case number 2, and they may single or in multiple cognitive domains, and the person's functionally independent, so no significant. They may have some changes, but they're still able to live independently. And not all patients will go on to necessarily progress to dementia. And what is Alzheimer's disease? So cognitive decline in multiple areas, like I mentioned with the patient case 3, memory loss, and at least one of the following, usually naming problems, visual spatial function deficits, so getting lost like he was driving and he had stopped 2 years before, and a functional impairment, so a decline from the previous higher cognitive function, so he could no longer live independently, and gradual and progressive decline. So what about progression and prevention of Alzheimer's? So we think of cognitive function, so how you function day to day, not just your ADLs, but even higher order ability to function, and then behavioral changes. And so all of these things, when they become impaired, the overlap is Alzheimer's disease and related dementias. And some, like the frontotemporal dementia, the behavioral variant, behavior is the change you see first, and then you might see cognitive and functional impairment. So again, this is something we follow with all the patients. And there are specific things that we can do to assess each one: cognitive function, functional independence, behavior, and then global function. So I'm going to quickly go through the different stages pathologically and clinically in Alzheimer's disease. So on the right on each of these slides, you can see a cross-section of the brain, right? So left and right. And then a sagittal, so section. And it sort of mirrors what Dr. Dubroff was showing in the PET imaging and the MRI. So, but these are more like brain sections, and it's pointing to the hippocampus, you can see. And then on the one on the right, that's sort of that blue sort of drawn in, that's showing that there are some pathological changes, the amyloid and the tau in that area, and that corresponds to the memory loss, which is the first sign of Alzheimer's. And those changes, as I've mentioned at least twice, that I always tell students, if you hear something 3 times, it means you need to really know it. So cellular changes can begin 10 or 20 years before the symptoms. And the signs are first noticed in that area I just mentioned, and then eventually those areas atrophy or shrink as the cells die and the functional networks and the cells are disrupted, cellular signaling. Mild cognitive impairment or minor neurocognitive impairment, the cognitive decline and functionally independent, as we mentioned, like case 2. And then as the disease progresses, mild signs include, and you can see again how that blue, see how it's spreading now along the temporal lobe and then in the frontal cortex up into the parietal. I don't know, is this the pointer? So here's the temporal lobe here where the hippocampus is, up into the parietal cortex here, and in the orbital frontal, in the frontal cortex here. And then you can see how the brain is starting to shrink. See this temporal horn, so that's where the cerebrospinal fluid is getting larger because this adjacent structure is shrinking because of the pathological burden. And they get more difficulty with word finding difficulty, handling money, poor judgment, mood changes, anxiety, and as it develops more moderate phase of Alzheimer's, increased memory loss, problems recognizing people, increasing problems with language and other cognitive operations, restlessness, agitation, some of those behavioral changes, wandering and repetitive statements. And again, remember, it's amyloid and tau spreading through the brain, and then atrophy, cerebral atrophy or brain shrinkage as more and more neurons stop working and die. And that's, the hippocampus, as I keep mentioning. And so this is more of the end stage in severe Alzheimer's. And a lot of times, like the cases that I presented, many people with Alzheimer's are really healthy, and so they can live for many years. And it's really, really hard to watch because the person is still present, but not. I think that's really difficult for family members and loved ones. So the cognitive function is severely impaired. They can't speak. They can't even recognize loved ones at this stage. Symptoms can include increased sleeping, bladder and bowel dysfunction, difficulty swallowing, weight loss. In severe Alzheimer's disease with brain atrophy, the patients are completely dependent on others for care. It's really difficult. Caregivers can turn to hospice for help in palliative care. Again, you can see, look at the difference, and the difference here with the spreading throughout the brain, right? So we have the cognitive, functional, and behavioral changes. So what's exciting and what's changed in my discipline is probably within the last 5 to 7 years, we start to think of Alzheimer's disease as making a diagnosis based on biomarkers even before or at the milder stage in terms of cognitive decline. And the idea to me is that as we progress over time is that we treat people earlier and earlier in the process. But the classification on these biomarkers includes cerebrospinal fluid studies of amyloid and tau in a specific ratio, but molecular imaging is actually the one that is paid for by insurance companies at this point, particularly because the drug treatment that is FDA approved and is tied to the amyloid, the most reliable thing to look at from the initial studies going into phase 3 and now phase 4 is that there's a burden of amyloid and you treat the person, and over those 18 months in the clinical trial, the amount of amyloid was reduced, and you could look at it in a picture. So it was a show and tell with patients, which is really kind of amazing. And this just shows this classification that we use, in terms of as a scientific approach, but also really as clinicians, is that when you look, if I can, like I said, I'm challenged as a left-hander. So, so you look at this, so this CSF A beta, so that's the amyloid, 42 is the toxic form, 40 to 42. So that maybe you see those changes early, then amyloid PET can be detected, because this is over time, and you can see the person may still have normal function before they develop dementia over time, but you can see these changes many, many years earlier. And again, the CSF tau, the MRI and FDG PET, then you start to get the cognitive impairment. But see, right very close back here, looking at amyloid PET changes. And that's why we think it's a really important clinical tool. And again, this just shows, from an article looking at the different biomarkers. And this is an advanced classification where they're also looking at X, which would be other biomarkers. So we're talking about, neuroinflammation and other things that would be targets that are drugs in the pipeline. And so the care team, includes the primary care physician, the dementia specialist like me, but also community organizations like Dolores was saying with the Alzheimer's Association, and resource specialists. We have the dementia specialists that we just got approved at the state level. But again, you hate that expression. It sounds cliche to say it takes a village, but it's really difficult. And then we need to address other causes of cognitive decline. So when you see the physician, they look at it's really important to get a good history to see if there's other things going on. Drug use, is the patient, did they just have knee surgery and they've been on medications for pain for a protracted period of time? Do they have a history of anxiety and they're on anxiolytics that disrupts cognitive function and sleep? Can we, or some of those factors? So we have to really get a medical history, and we have to treat things and do a variety of tests, the lab tests. But again, now I would add not just the structural imaging, but if the referral is to a dementia specialist like me, or like mentioned, a geriatric psychiatrist, then oftentimes molecular imaging and FDG PET is really recommended as part of the diagnostic process. There's also genetic testing that, it's not necessarily going to make a diagnosis, but it's important because there's a caution with people that have ApoE, especially the double allele. They may be more vulnerable to adverse effects of taking this infusion therapy for targeting amyloid. So this is just quickly the timeline of Alzheimer's disease development. So this is the symptomatic treatment starting in 1993, and then going really then there's a gap of 17 years. And a lot of it was that, there's been so much money, from NIH and other foundation support and pharmaceutical companies to develop drugs to treat Alzheimer's, because it's a health crisis, if you will, with our population aging and at risk. But now, from 2017, now we have the development and shifting. So, again, 17 years of no FDA-approved new treatment, but now we have disease-modifying drugs, and it's really exciting. And so this is, to me, this is the end of the story, really. Normal subjective cognitive decline, mild cognitive impairment, and dementia. But a lot of it is that we want to, and this was talking about Louisiana. I guess we can just go quickly through that. I kind of mentioned it to y'all. But this is really the end of it, is that what we want to do is, there's normal cognition, and then there's this change, mild cognitive impairment, MCI, and dementia. But with treatments, are we going to be able to do this, stabilize people with mild cognitive impairment so they don't progress? It's really much better for society, for the individual, for the family. What about if we can revert people to normal function with these disease-modifying treatments? It's important to remember, so I know this can be like kind of one of those Debbie Downer talks, but we always are optimistic because it's really true. 1 in 3 cases of people that would potentially go on to develop dementia, it's preventable. And so I try to be positive with patients and give people hope. But I think the best thing is that we do have new treatments, and we do have partners in our nuclear medicine physician friends who keep developing these tracers and doing studies so that we understand how to apply it clinically. And the drug development is really exciting. So thank you all very much.